My name is Matt. I'm from the London School of Hygiene and Tropical Medicine, and I'm going to introduce the Viewpoint session on why should public health interventions consider agency. This session involves two presentations, one by Dr. Jean Adams, who co-leads the Population Health Interventions Programme at the MRC Epidemiology Unit at the University of Cambridge, and the other by John Coggan, who's Professor of Law at the Centre for Health, Law and Society at the University of Bristol. Jean and John are going to speak for about 10 minutes each on the topic, why should public health interventions consider agency? And then there'll be about 10 minutes for questions. So please do pop your questions into the stage chat and ask them as they occur to you. We'll deal with them at the end, but if you think of them, just type them away. And there's also the links for two relevant articles from the speakers, which will be added into chat. And that's my bit, I think. I will pass on over to Jean and then John.
Thanks, Matt. Let me see if I can work out the slides. Does that look good? Yep, okay, I trust that it does. Thanks, Matt, for the introduction, and thanks. It was originally Yoav Ben Shlomo who invited us to speak, so thanks to him as well, and to the organisers for making this event happen. It's really nice to be with people who I haven't seen for a long time, even if just kind of virtually. So the story of how we got here starts, I think, about 5 years ago when, with colleagues in Cedar, I wrote a paper about the role of, can I make my slides go forward? Okay, here we go. I wrote a paper with colleagues in Cedar about the role of individual agency in population interventions for diet and obesity, which I think the link was in the conference pack. Then more than a year ago, Yoav, in preparation for the original version of this meeting last year, put John and I in touch and told us that he thought that we might have something interesting to say to each other, and maybe that we could say those interesting things in front of a conference audience. So it did turn out that we did have some interesting conversations, and the meeting obviously went into hibernation for a year, but John didn't. He got very busy and kind of quick as lightning produced both a baby and a further paper based on our discussions. And the link to that second paper is also in the conference pack, I think. So I think we're going to use this time to share some very brief outlines on our different perspectives on this topic. And then we want to have a good amount of audience discussion. I think the session was originally pitched as a debate, and it was never considered by either of us to be that. So I am sure I'm kind of preaching to the choir with this audience on a lot of this thing. So I'll keep it brief and really just provide some background to give us a point of focus and make sure that we're all on the same page to start with. So this figure shows trends in age standardized preventable mortality in the UK. In 2019, about 14% of deaths in the UK were considered preventable by either effective public health or primary prevention methods. And obviously that mortality hides behind it a lot of associated morbidity. Much of this preventable illness and death is generated by environments that don't support people to live their healthiest lives. And lots of that has already been discussed today. Environments that discourage cycling to work or make it easier and cheaper to eat cake than fruit, or don't provide the financial support that's required for people to take time off work when they're sick. So we all know this, or we wouldn't be here. And I suspect that you also all know about Rose's strategy of preventive medicine and his arguments in favour of the population approach to prevention. I think maybe a common thing that gets forgotten when we're talking about Rose is that he saw the alternative to the population approach as the high-risk approach. So the high-risk strategy involves identifying people at high risk of disease, often with screening, and then focusing our preventive efforts on those people. So we make a great deal of effort to find Wally amongst the population and then deliver our interventions to him or to Wanda. And the problem with this approach, as Rose described it, or one of the problems, is that whilst we are not very good at predicting disease, and so only a small proportion of disease arises in those people that we identify to be at high risk of it. And so Rose obviously proposed the alternative population approach, and rather than making an effort to find Wally or Wanda in the big picture, we just treat the big picture and we deliver interventions to everybody. So one of the things that I think happens when we get into discussions about the population approach is that people assume that the opposite is an individual approach. And I think that that can often lead to discussions going kind of derailing quite quickly. So I hope I've made clear that Rose didn't talk about individual at all. And in fact, you can have population approaches to prevention that involve one-to-one interactions between healthcare workers and citizens. And a vaccination program is a really good example of that. The vaccination is delivered to everybody, but in a fairly kind of individual setting. So in this paper that I wrote with colleagues a number of years ago, we described that not all population approaches are created equal. And the thing about the population approach is that while interventions are theoretically available to everybody, not necessarily everyone can benefit from them equally, and that may generate or reinforce inequalities. This poster of the kumquat is one of my absolute favourite pieces of health promotion, and I remember it as being a campaign on bus stops in mid-1990s Edinburgh, but when I looked for it online, the history of it was different, so my memory may be entirely wrong. So I love the absurdity of the kumquat having a role in health promotion. But this poster is as a population intervention. It was on bus stops. I'm fairly sure that that is definitely the case. But for this poster to make a difference to your health, you have to put quite a lot of effort into it. So you have to read it. You have to understand it and operationalize the message. And the message is actually not that clear. Like, I'll put some examples here, but it's not very clear what it's telling you to do. You then have to remember the message, and you have to enact the message when you have the opportunity to do so, should you have the opportunity to do so. And all of this takes personal resources in terms of cognitive, psychological, time, finance. And again, I'm sure I don't have to point out to this audience that those resources are not evenly distributed across the population. And there's a risk if we rely on population interventions that require individuals to use their own resources to benefit from them, then we'll reinforce or even exacerbate existing inequalities in health. So in our paper, we termed the amount of personal resources that people have to use to benefit from an intervention the degree of individual agency required. And we saw this as distinct from the population high risk distinction that Rose described. So we simply put them on X and Y axis. And we also, I think, conceived of these as not necessarily simple dichotomies, that there's something in the middle, that there's kind of grey area. We can maybe think of these as continuous concepts. So we can provide examples across the field of diet and obesity of interventions across this intervention landscape, I guess you might describe it. So as we all know, Rose proposed that population approaches, so things at the bottom of the figure, are more likely to achieve greater gains in population health. And we argued that lower agency approaches are likely to achieve more equitable gains. And so you get this sweet spot in the bottom left of the figure where low agency or lower agency population approaches are more likely to be more effective and equitable. And with that background, I'm going to pass on to John.
Many thanks, Jean. And just before talking to my slides, I'd just like to express my thanks to Jean, both for being a really outstanding co-author, but one who has also exercised in extreme patience in dealing with me as I've badgered you, Jean, with emails as this work's developed. My the interest that provoked this what's become this talk and the paper Jean's referred to was it was all stimulated by a discussion that Yoav was leading in the University of Bristol, to which I was kindly invited, and there were other colleagues and students there, and we'd read the paper that Jean and colleagues had written. And my background, as you've heard, is I'm an academic lawyer, but I've got very significant interest as well in questions of political philosophy and social ethics, and I've applied those over the years to questions of public health ethics. And so when I read the paper, and this is why Jean is right, that this was never going to be a debate, it wasn't about disagreement, but it was about reading it through a different lens. And I was very interested in the questions of equity and effectiveness held against questions of public health ethics. And what the first paper does is provide a clear evidence base for reasons why, as it were, from a public health perspective, we could question the effectiveness of the policies that had been implemented by the government at the time. And implicit within that was that this is an ethical problem. So there weren't just scientific questions at play, there were also value-based ones at play. And the framing in that paper did it against what we might characterize as the moral mandates of public health. And I reproduced those here in the first 2 bullet points. So broadly speaking, we have ideas that if you're attracted to public health as a vocation, you have a commitment to the idea that overall population health improvement is a good thing, and also the reduction of health inequalities is a good thing. You also, consistent with what Jean has been saying, have a view that there's a shared responsibility for health across society, and addressing questions of public health raises obligations for government and other partners in society. And I read the paper very much as being framed against those questions, and also suggesting that there was some failure, because although maybe health outcomes were improving, the spread of these, as Jean has explained, weren't obviously equitable. Jean, if you could just flick on to the next slide, please. Jean already spoke to the idea that in some senses, with an audience such as the one sort of in front of me right now, there are issues about singing to the choir. And when I engage in public health ethics research, training, or education, I try to insist to my audiences that we can't start, or at least can't remain, working from these moral mandates from public health, because what we're looking at is policy writ large. And so the question that this talk today addresses, I think, requires us to look at social ethics and questions of political theory more broadly. So we need to look beyond public health and then see where these ethical mandates of public health sit within that. So on the right of this slide, there's a sort of caricature of the nanny state. And of course, that can be what stands in the way of having other than a high agency approach to public health policy, is you have critics who say we mustn't be interfering in people's freedom. So whatever else we care about, health, equity, anything else, comes second to freedom. And if we're going to interfere with freedom, that's a problem. Now, from a social ethics perspective, that means I think we need to go back to the 3 questions that are bulleted here. And there's quite a lot of text on the slide. I won't read it all, but perhaps this can come out in discussion. But I think these are the 3 core issues that we need to tackle within a public health community if we're going to advocate for more effective, more equitable public health measures in society. So first of all, what makes for a legitimate, fair, and mandated policy aim? And here we may see good words, even in in all sorts of government statements, and we all know that health inequalities are right at the fore of governmental discussions right now. So we need to look at how, as a society, questions of health inequity are owned as a shared problem. But then just settling on the aim isn't enough, and I think that's the cause of frustration for many people in public health communities about how effective or otherwise policy might be. However, we don't want to live in a health theocracy, so there's no problem in technical jargon in seeing side constraints on policy. So we want to look to the ethical limitations that rightly constrain what governments might do in the name of health. So, for example, what other democratic values are at play? How do human rights feature in the mix? And then how do we go about questions of balance across different aims, including but not limited to public health aims. And finally, how do scientific evidence bases fit within these discourses? And in particular, what do we do if there's a poverty of evidence in regard to the effectiveness of proposed strategies? Jean, please, can we go to the next slide? So those are the big picture questions which I'll leave floating. The final slide from me for now refers to the 4 conditions that Jean and I speak to in the paper that we co-authored. These conditions are drawn from an ethical conceptual analysis of what is argued in the earlier paper that Jean led. And it came across, of course, as well in the slides that Jean just spoke to. But these 4 conditions all need to be met if a high agency approach is to be successful. And I think that what we argue, otherwise I just speak for myself, Jean can clarify afterwards, but is that really the overwhelming focus is on condition 2. So the arguments in favour of high agency approaches relate to those nanny state ideas, the idea that we respect individual autonomy because adults know how best to decide for themselves and as relevant for their children. And that is an important principle in any liberal democratic society. But if we're going to rely on choice, we argue that that choice has to be meaningful. And that's why you see these other conditions as well. It's no good saying that somebody has powerful agency because she has her own autonomy if she lives in a social and commercial environment that doesn't meaningfully provide healthy choices. If you can't get food that will be conducive to your good health, then your agency doesn't come to much in relation to improving your health. Similarly, you have to be motivated to engage with the policy measure that's been implemented. And as Jean indicated, that comes at its own costs, and we can't take for granted that they're costs that people will be willing to expend. And finally, there needs to be actual deliberation. We know, for example, about the role of behavioural psychology, behavioural economics, and other such disciplines within public health discourses. But if we're actually interested in agency, it ought not to be about looking for ways around deliberation. It ought to be based into ideas on deliberation. So I will end my part of the talk there to allow us some time for discussion, which I look forward to. Thank you, Jean.
Hi there. I think I'm back again. Thank you both for that. So yeah, if you've look at the right of your screen, if it's anything like mine, you'll see something saying stage at the top right, and if you press that and make sure that you're onto chat, you should see the chat that's relevant to this session. I believe that's right. That's what's worked for me anyway. It'll take probably a while for people maybe to think of questions to type in. So while you do, I think I'll ask 1 or 2 questions if that's all right. The first one is about this idea that perhaps we should be advocating moving to low agency policies. And the question is really, if those are considered very interventionist policies, what kind of threshold do you think is regarded as acceptably interventionist or too interventionist? And perhaps 1 or 2 examples might be handy.
Jean, do you want to?
No, you go first.
Well, I'm happy to start to answer that. I think first of all we need to have a discussion about a public discussion. I mean, not just here, but about why the high agency ideas are being valued in the first place. And that will then allow us to understand where the offence is, if there is an offence, in moving to lower agency ideals. And I think that we can often find in policy, in the presentation of policy, a bit of talking out of both sides of one's mouth. So on the one hand, we say we need to respect people's autonomy, that second condition that we refer to, because it's so important that people decide for themselves. On the other hand, we know that people aren't motivated, to deliberate, aren't engaged in those deliberations. So we'll bypass agency. If we think that second part is okay, then I think that opens the door to the discussions of where and on what basis we can move to lower agency interventions justifiably. I don't think it's consistent for a government or any advocate in relation to public health policy to say that we need to prize autonomy, we need to prize autonomy, we need to prize autonomy, and we don't need to worry about whether people are in environments that allow them to exercise it well.
Okay, do you want to try anything?
Yeah, I think I might add to that. I think actually having listened to John more and more, and those 4 conditions that he put up, I think the focus on lower agency interventions is really a mitigation in the context of environments don't support healthy living, right? That if we were able to provide the other 3 or meet the other 3 conditions, then condition 2 of autonomy is important would be fine. And I guess maybe this is, like it would always be great to have an RCT, but we can't always deliver one. This is almost the same argument of if we are not able to provide an environment that's supportive of people, then we have to think of another way to help achieve the aims of policy as stated, of helping people to eat better, move more, etc., etc.
Okay, thanks. We've had a bit of time now for some questions to appear. One from Jenny Poppe, who's, I think she's asking about the maybe the meaning of agency varies by who you are and what discipline you come from, whether it's social psychology or lawyer ethics kind of discipline. And so she asks, I wonder if the important question for public health is what understanding of agency should be embedded in public health interventions. For sociologists, agency is intimately linked to structure and encompasses notions of power. E.g., agency refers to people's thoughts and actions that express individual power. Does anyone want to have a go with that?
I don't want to comment on how other disciplines understand the term. It feels like not my place. Like I'm not a sociologist, so I don't feel able to speak for sociologists. And even if I was, I probably wouldn't feel able to speak for them all anyhow. But I think that's not unlinked to what we're using the term to mean in terms of how much individual resources people have to put into an intervention to benefit from their health. And of course, that those are linked to things about structure and power. And I think that maybe what I've just said comes back to that if you're in an environment where the structures are mitigating against you, then you don't have the power to necessarily live the life you might want to.
Yeah, I think I think it's a really crucial question. I think it's an excellent question, and insofar as it's framed against disciplines, I likewise don't want to sort of start speaking back to literatures that I don't know and wouldn't understand probably in the proper way if I read them. But from the way the question is phrased as well, the important question for public health is what understanding of agency exists. And one of the things that motivated me towards this paper, Jennifer, is that it seems to me that we have 2 inconsistent understandings of agency operating, for example, in relation to the nudge unit. So on the one hand, you say we've got all this evidence from behavioral economics that tells us that people do not make these sorts of rational decision makers that classical economic models would tell us they make. And so we need to reconceive agency in people's decision making to help them improve their decision making. And that's based on an empirical footing. At the same time, we say we've got this commitment to a philosophical libertarianism. So we have a commitment that we want to hold on to the idea that people are actually just well able to make good decisions for themselves no matter what. And those 2 things seem to be inconsistent to me. And so I think part of the problem isn't just asking which concept of agency we should use, but recognizing that we have more than one operating concurrently in the current policy climate.
Okay. I think David Taylor Robinson's question tries to sort of highlight that these things are not necessarily dichotomized and that over the life course, so say social determinant approaches to public health that apply to young people could increase their agency and their capabilities later on in the life course. So the idea is that they're not entirely separate things. Would you like to comment on that?
Yeah, and I've just flicked through and I see that the capabilities get some mention through Nussbaum's work as well, and there's also a question about where these things come. I mean, I think in relation to children, different obligations arise anyway in relation to what governments can do, and in that sense, it makes it easier to be, quotes, more interventionist, because it's easier to ground obligations on the state to determine how decisions ought to go. I think anyone who starts with SENS analysis is onto a very good thing. So I don't think you can argue against that. But I think when you're then talking about adults, however compelling the evidence in relation to life course epidemiology, whatever it may be, the actual business of providing for lower agency interventions becomes much harder to justify at a political level. But I think, for example, Sen's work or Nussbaum's reinterpretation of it provide a very good foundation for doing that.
Okay.
I think we could have a discussion as well whether those interventions that David's listed do increase agency or change the environment.
Mm-hmm. In relation to those questions, I should say for colleagues who aren't familiar with it, the work of Sridhar Venkatapuram is really excellent on this, and he's done lots of work for some years, and including with I think Sen might have actually examined his PhD. He's done work with Michael Marmot, and what Sridhar argues is that we can't think about social epidemiology without thinking about questions of social justice, which he approaches from this capabilities perspective. And he says you can't think about social justice without taking account of evidence from social epidemiology. So we need to tie these things together and recognize that, the way someone like me, for example, tees things up and says, well, we got our empirical and then we got our ethical, our value-based stuff. These things can't actually be divorced. They're intertwined.
Okay, we haven't got that much time left, actually. I'll ask one more question from Mark Pettigrew. Are lower agency interventions also ethically problematic if they mean that people's behavior is entirely shaped by environments? And he adds...
I think...
Yeah, go on.
I think they could be seen as that, and I think that's one of the reasons why they're politically difficult. Well, I guess the nudge unit's all about that. It's changing people's behaviour without asking them to think about it. And so the conclusion I've come to is that if we agree democratically that these are our aims of policy, then I can engage in a discussion about how might we best achieve those aims. But whether or not those should be the aims of policy is, I think, worth discussing.
Yeah, and just quickly, Mark, they absolutely are, right. And they invite critique. And those first three questions I put up, those are the ones that need to be asked to evaluate those matters. Okay.
Thanks very much. We've got a burst of questions right at the end, but we're out of time, including a clarification from Jenny about what she was trying to ask with her question. So apologies if I didn't quite convey that. But we are at the end of our session. Thank you very much. And we are moving on to the next part now. I have to deliver a short message about what happens next. But before I do that, just thank you very much to Jean and John for coming in and presenting their work. And do look up their articles, which they're really good. I've read them and will now start citing them as if I know, as if I know all about it. Thank you very much.
Thank you.